Okay, so hi everyone. Welcome to the noon meeting. Itumeleng is an MEd student and he has completed his thesis for which he got a distinction pass. So today you're presenting the essentially the findings of his thesis. So we were particularly interested in looking at predictors and correlates of post-traumatic stress syndrome in EMS staff. Thank you.
Thanks, Prof. I will now just share. Good afternoon, everyone, and welcome to the noon meeting. Colleagues at the HIA as well for joining, and I see a colleague from the BBC as well joining. Welcome. Okay, just can you everybody see?
Yes.
Okay. I don't think I need to switch off my video. I'll keep it here to keep everybody entertained. So as Prof has mentioned, that I will be doing giving a brief overview of the study that was done in our EMS population within the Western Cape, and really discussing the prevalence and the correlates of post-traumatic stress disorder among ambulance personnel. I will go through a very brief background as to how the study came about, a very brief literature review, look into the research questions that we undertook to look into, the aims and objectives of the study, very briefly again on the methodology that we employed, the measurement tools that we used, and really spend a large part of this presentation on the results, which we found quite interesting. And of course, some of the discussion points and the take-home messages will be discussed, and of course, the limitations of the study and really in general cross-sectional studies. I put this article here because really it represents what many of us see in the news, many of us hear on radio and so forth about the attacks on our EMS staff and the impact that it has been having on the services in general. As a form of a background, really just in terms of looking at emergency workers across the globe, and this includes ambulance personnel, it includes firefighters, it includes police officers. So worldwide, they're often the very first to be called upon in violent situations or traumatic situations, and they are exposed to a number of occupational hazards. In our setting, we've seen an escalation in attacks and exposure to traumatic incidents, and these are really some of the figures that we have had in our own population, where in 2014, from 2014 onwards, you started seeing a large increase in the number of attacks that EMS staff were experiencing. What types of attacks were they experiencing? From 2015 onwards, you see an increase in the number of assaults, robbery, theft, civil unrest, and in particular, threats, general threats, and random stoning as well. The impact has been felt on the service, as you can see here, that with the increasing numbers of staff that have been involved, we've also had an increase in the number of hours lost, if you compare 2016 and 2017, for example. And of course, the situation raised a number of questions, both for EMS staff and those who are within the management. And really, many of the questions were around what has been the psychological impact of the rise in attacks, how can we as a service better support ambulance personnel, and for those who are already in the service, what are some of the barriers that they are facing in accessing care, and can we understand a bit more what the literature says regarding trauma-related mental health conditions. And I have previously presented at this forum the literature review around this, so I'll just literally touch on some of the key findings. As I've explained, that the ambulance personnel, similar to the other frontline workers, are exposed to a number of occupational hazards in the course of their career. Ambulance personnel are unique in the sense that they are mostly, or those in the operations are mostly in the field, so they have to respond to normal everyday emergencies. If they're natural disasters, they have to respond. We've just had a pandemic, they have to respond. Industrial incidents, criminal attacks, or massive public events, stampedes and so forth, ambulance personnel are often called upon on to respond, and they face multiple occupational hazards ranging from physical to ergonomic hazards. But I will focus more on the psychosocial hazards, and these include shift work, the impact of shift work, sleep deprivation, trauma and critical incidents exposure, and then this is both acute traumatic exposures or exposure to critical incidents, and of course more chronic exposures, and then the effects of bullying and harassment. Those are some of the psychological hazards that are faced. However, as I said, I'll focus mostly on the exposure to critical or traumatic incidents. So, exposure to work-related stressors has been linked with the development of stress reactions, and these stress reactions include PTSD and other trauma-related conditions. PTSD, so post-traumatic stress disorder, commonly occurs as well with other psychiatric conditions, with about 80% of PTSD cases being additionally diagnosed with comorbid conditions such as depression, substance use, and anxiety disorders. And ambulance personnel have also been shown worldwide to have an increased risk of PTSD in comparison to the general population, but also in comparison to other frontline workers. And I show here some of the two systematic reviews and meta-analyses that have been well quoted. The first by Berger does show that it did a meta-analysis of the PTSD prevalence in rescue workers, and this is a very broad term of including ambulance personnel, firefighters, and others. And the PTSD prevalence was found at around 10%, however, was found to be at 14.6% in ambulance personnel. And as you can see, compared to the general population of 1 to 4% of PTSD prevalence, it's quite high, and in very much so also in comparison to other colleagues, firefighters and police officers. Petrie, the next study, also found a pooled PTSD prevalence of 11% in ambulance personnel, but also found 15% of depression. So the prevalence of depression was 15%, anxiety disorders, and general psychological distress. Interesting was a review of compensation data in Australia, and they looked at, they compared ambulance personnel with nursing professionals, both for musculoskeletal disorders and mental injury. And for mental injury, which includes PTSD and other mental health conditions which were reported, the hazard ratio was significantly higher than in ambulance personnel in comparison to nursing professionals, both within the period of 2003 to 2005, and really showing interestingly there an increase in 2009 to 2012 as well, and a hazard ratio that is at least 13 times more in ambulance personnel compared to nursing professionals. And of course, some of the explanations the literature has sought to find out is that perhaps ambulance personnel are responding to a greater number of calls in comparison to other frontline workers. They have more sustained work pressures and stress while on duty. They often have greater personal contact with patients, for example, in comparison to the police service or firefighters, and not only the patient but their families as well. And this possibly may increase feelings of guilt, of blame, of worthlessness, where there's failure to assist a victim timely or successfully. What are some of the predictors or the correlates that are known in ambulance personnel? So we are aware that exposure, so increasing exposure or certain types of critical incidents or traumatic stressful situations have been linked with the development of PTSD in ambulance personnel. There are certain demographic factors that have been linked, so those who are of a younger age, female gender, being less educated or occupying lesser ranks within the ambulance service. And then other predictors were workplace factors, so chronic operational or organizational stress, conflict with patients, lack of social support, pre-existing psychiatric illnesses, and poor coping mechanisms. In our setting, the PTSD prevalence has been found to be between 6% or rather 7% in 2005 and 16% in a study that was done in 2014. A very interesting one that was also done by Minnie had found asked EMS personnel as to what were some of the most traumatic encounters, as I've said, that the frequency with which they happen, but also the nature of the traumatic encounters. So what was interesting and that came out was that the most traumatic events that were experienced were incidents involving children, if there was serious injury or death to a colleague, and of course the death of a patient in one's care. So the research questions, therefore, that we came up with after having looked at the literature and engaging with staff on the ground and management and others were: what is the current PTSD prevalence in ambulance personnel within the Western Cape province in South Africa? What are some of the risk factors or correlates which have which are associated with increased risk of PTSD? And what would ambulance personnel within the service, how would they like to be supported, and what are some of the barriers for them seeking care whenever they need the support? Therefore, the aim of the study was to determine the factors associated with increased risk of PTSD and the preferred supportive measures for work-related personnel. The objectives were emanating from the research questions. As I said, we'll look into the prevalence, we'll identify the socio-demographic and occupational risk factors, we'll look into the supportive measures, and then the barriers faced. In terms of the methodology, the study was a cross-sectional study, and it involved all Western Cape government ambulance personnel within the 50 bases, and this was conducted between November and January last year. And just a questionnaire, electronic questionnaire, was distributed to all ambulance personnel, and these were those in operational roles. So those were operational roles you'll see throughout the study. I'm referring here to those who are providing direct clinical care on the field or on the ground, and then those in support roles, in support service roles. So those would be those in the call center or the dispatch area, those working in administrative roles, and so forth. And of course, hard copies were also made available for those who did not have access to good internet, and all of these were returned in sealed envelopes to me as the researcher. There was no exclusion criteria applied to the study, and informed consent was required before participating in the study. The study was approved by to be conducted by the UCT's Human Research Ethics Committee. What were the type of measurements that were used? So there was a self-administered author-designed questionnaire, and this looked at socio-demographic data and occupational data, and you will see in the results, we looked at some of the mental health and medical history, so both one's own mental and medical history and one's family's ones. We looked at smoking, alcohol, and illicit substance use, and we thought we should separate this from the use of prescription medication. So that was also a question that was asked, and we used the CAGE questionnaire in order to elicit problem drinking. So if you had a score of greater than 2, so for those who are not familiar, the CAGE questionnaire is used for assessing problem drinking. So if you had a score of 2 and above, that was indicative of problem drinking. And of course, we asked about a range of barriers that were faced for seeking help, and the participants could choose from those, and also a range of sources of support, and participants could choose from those. To assess for PTSD symptoms, we used the impact of event revised the impact of event scale, the revised version, and this was asking about PTSD symptoms in the past week. So the week prior to when the participants was completing the questionnaire, and this is in relation to a troubling critical incident that was encountered in the line of duty. So you had to think about whether you've got the symptoms, and then you also think about those symptoms in relation to one of the most troubling events that you encountered in the workplace within the past 6 months. This is a validated questionnaire using 22 items, and it covers the 3 PTSD symptom clusters. And higher scores are indicative of greater symptomatic stress, and we use a cutoff of 35, which defined our definition of a PTSD case, or probable PTSD case. Other measurements that we used included the Connor-Davidson resilience scale. This is a validated tool as well, and it was used to measure resilience and scored on a 5-point Likert scale. Higher scores on this indicated greater resilience. and the scale has been noted as being reliable and an efficient measure of resilience and used across the globe as well. And of course, we obtained permission for use from the authors for this. To measure the type of incidents that are, or traumatic events that are experienced, we used the critical incident inventory, and this is a validated tool as well that lists the number of critical incidents that are encountered in the line of duty, and the tools that were used are very specific to the EMS population or the ambulance personnel. And activities include those, such as witnessing a death or injury of a child, being seriously injured, or witnessing a colleague injured, and so forth. Other tools that were used included the chronic stress questionnaire, and here this was used to assess for exposure to and perceptions of chronic stress. It was used to assess both organizational and operational stress within the workplace, and this was on a scale consisting of 10 questions each. So operational stress, here we're referring to structural elements within the working environment of EMS, so such as shift work, the risk of being injured in the line of duty, fatigue, and so forth. Whereas organizational stress, we're talking about factors associated with the culture within the organization, so conflict with managers, staff shortages, and so forth. Then the quality of, just as a measure for quality of life, we assessed reduced quality of life and interference with occupational functioning using the SF36Q quality of life scale. We only took 3 questions from the broader questionnaire, which has 36 questions, and we looked at those that were focusing on occupational functioning and emotional problems related to that. Okay, so that really was just a very brief rundown of how the study was conducted and what tools were used. So now I will be looking at the results that came through from the study. I thought this was a nice cartoon showing how much we had to push to get these results, but eventually we did. So we distributed 2,000 questionnaires to the EMS personnel within the Western Cape. 473 were returned, and this represented a 24% response rate. 2 were, however, duplications, and 88 were incomplete, therefore could not be used in the analysis. At the end, we analyzed 338 entries. So just focusing on the demographic and occupational qualities of the participants. The majority of the participants were females, with 55% of them, with a median age of 38 years, and majority spoke the languages within the Western Cape context, majority English and Afrikaans, and a majority of them also had a higher level of education, so either a certificate or diploma or degree. Almost half were married, and the other half was unmarried, with only 10% that were divorced. And what was interesting was that a majority lived within the urban areas, and they also lived with family as well. So 80% lived with a family or a friend. In terms of the job categories, so 70%, so 71%, or around 70% of the respondents were from the operational services, whereas 30%, around 30% was from the support services. And this really reflects what is currently the structure within EMS in the province. Many of them had been in their roles for over 8 years, so quite a stable workforce. And what was interesting as well was that when asked whether they had been a job change in the past 5 years, around 25% admitted to having had a job change, but this was mainly due to promotions and less so due to medical reasons. Very interesting in terms of the general and mental health specific variables. When asked about smoking history, around 30% of the participants admitted to smoking. Around 50% admitted to alcohol use, and this translated to around 200 participants. And of those 200 participants, the questions around alcohol misuse, we found that 27% of those who are currently using alcohol had evidence of alcohol misuse, so had a cage score of greater than 2. Interesting as well is in terms of illicit drug use. So those currently using illicit drugs, and these are non-prescription drugs, so found on the market, and about 3% of the participants admitted to using illicit drugs. And at the bottom, we tried to find out the relation between the use of substances and whether or not participants would actually use substances or perhaps use substances for managing work-related stress. And it was interesting that 30% or close to 30% had said that they felt the need to smoke to manage work-related stress. And that was interesting because, as I said right at the top, that current smokers are around 30%. So the need to smoke or the need to smoke to manage work-related stress were around 27% of the participants. The use of prescription drugs to manage work-related stress. So this would be prescription drugs that were written or prescribed by a health professional. So 17% indicated that they felt the need to use prescription drugs to manage work-related stress. Around 11% felt the need to drink alcohol to manage work-related stress. And around 4% indicated that they felt the need to use illicit drugs in order to manage work-related stress. Other mental health variables. Those who had ever been diagnosed with a mental health condition were around 11%, and around 7% admitted to treatment for a mental health condition. When we used the impact of event scale, we calculated a PTSD prevalence of 30% in all the participants. The PTSD prevalence by gender was much more in females than in males. However, this was not found to be statistically significant, this difference. We also found, very interestingly, that the PTSD prevalence in the operational staff, so those on the road, was very similar, almost equal to that of those in the support services, and that was around 30% for both groups. We were also very much interested in whether or not the participants had actually ever received training on how to manage stress or what services that were available for stress, and 70% had indicated that they were aware of the services to manage their stress. However, when we asked about if there was any training specifically that was provided, 70% also indicated that they had not received any training. And then in terms of training on the access of services that are available, 70% said they were never trained on where to access services for work-related stress. And in terms of the barriers for seeking help, top of the list was that there was a fear that the services were not confidential, around 40% of the participants. Around 20% of the participants said that they feared that their careers would be negatively affected by actually seeking help. And others, of course, indicated that the difficulties of taking time off work and so forth. What was important, of course, for us were what were the preferred sources of support. So what were ambulance personnel, what did they prefer, who do they prefer to seek help from? So top of the list was the preferred source were the spouse or the partner, so around 63% of the participants. A family member or friend came next, and a spiritual or religious leader. And as you can see, these are all support structures outside of the workplace. Interestingly, all the support structures provided within the workplace occupied a lower preference. So right at the bottom, the use of seeking assistance from a union rep or a union leader was around 20%, and seeking support from the employee assistance program or the occupational health team was also much lower than seeking help from a spouse or family member. How could the services be supported, or how could they be improved, we asked. So top of the list was that the suggestion is that there needs to be training on how to recognize when one is stressed. There is a need for having a much more supportive management, so around 63%, and a need to address the staff shortages. We looked into the type of counseling that would be preferred. So presently, there is offers both on the premises and a telephonic service where EMS personnel could call in. And what was interesting is that so providing telephonic counseling was rated at the bottom of the list at 20%. And this was favored above providing the or favored less in comparison to the provision of counseling on the premises as well. They just beneath provision of counseling on the premises was allowing for debriefing and discussions as well within the team. Okay, and of course also training, again the training element, training supervisors to detect when colleagues are having features of work-related stress. So this really will now be a deeper dive into some of the correlates of PTSD that we looked at. So that and this reflects some of the findings that we reflect some of the findings that were picked up as well in the socio-demographic aspects. So we did bivariate analysis where we tried to find correlations between the operational stress, organizational stress, and just generally chronic workplace stress. And what was found was moderately positive associations between operational or chronic stress, operational, organizational, and chronic stress with PTSD scores. So the more the chronic stress, the more the likelihood that PTSD, the higher the PTSD score. What was also interesting, however, was the opposite for quality of life and resilience. So the higher the resilience score, the less the PTSD score. The higher the quality of life, and the less the PTSD score. We then did logistic regression, so both adjusted and unadjusted. And what was interesting was that for the unadjusted logistic regression, there was there was no significant the odds of PTSD was not dependent on age, gender, or education. But what was interesting, however, was that being a current smoker was associated with increased odds of being diagnosed with PTSD. And what you also find is that following the adjustments, so adjusting for age, gender, and education, the associations actually strengthened as well. So that was quite interesting in much of what I will be presenting, with fairly tight confidence intervals as well. So being a current smoker was associated with increased odds of being diagnosed with PTSD. Feeling the need to smoke as well was associated with increased odds of being diagnosed with PTSD, and feeling the need to use alcohol was associated with increased odds of PTSD. Interesting there that after adjustments, the odds ratio increased as well, almost doubled from 3 to 6.7. Other correlates that were found was that having a evidence of alcohol misuse, so the CAGE score that I spoke about. So those who had evidence of alcohol misuse had increased odds of being diagnosed with PTSD. Those who were current drug users had increased odds of PTSD. The confidence intervals there are, particularly after adjusting, are quite wide, but this was most likely due to the very small numbers that had admitted or reported illicit drug use. Feeling the need to use drugs was associated with increased odds of having PTSD or being diagnosed with PTSD, and feeling the need to use the prescription drugs was also associated with an increased odds of being diagnosed with PTSD. In terms of the job categories, prior to controlling for age, gender, and education, those who were working in HealthNet had increased odds of PTSD compared to the other groups. However, this association was not maintained once the adjustment was done. What was interesting then, however, was that those in the call center now had increased odds of being diagnosed with PTSD in comparison to the other groups. We looked at having just focusing on the reds, and I'll then talk about the other sections, just focus on the reds. So the mental health diagnosis, or being diagnosed with a mental health condition, I guess as expected, was associated with increased odds of PTSD, and then being on treatment for other medical conditions. So this is medical conditions other than a mental health condition was also was associated with increased odds of PTSD, and having emotional problems with regular work. So emotional problems in the past 4 weeks was also associated with increased odds of being diagnosed with PTSD. The other associations, the weak, were the associations between chronic workplace stress and critical incident stress. So those who had increased, so those who had chronic workplace stress or critical incidents were also had increased odds of PTSD. But interesting were that those who worked in the rural areas had less odds of being diagnosed with PTSD. Those who had better quality of life had decreased odds. Those who had better resilience had decreased odds of being diagnosed with PTSD. Okay. So what do these all mean? What do these what do these findings in relation to what is happening across the world mean? So we found, as I said, 30% of our participants in the study met the criteria for being diagnosed with post-traumatic stress disorder. This was higher than that reported for the general population, and this was in comparison to the South African general population, where PTSD prevalence is around 2.3%, and as reported, and as I said earlier on in my literature review, in other countries it's around 1 to 4%. The PTSD prevalence was also higher than that estimated in other previous studies conducted within the Western Cape in ambulance personnel and in other lower middle income countries. So I've said that the previous studies in 2005 found a prevalence of 6.7%, and another in paramedic trainees found a prevalence of 16%. In Egyptian paramedics, in a similar lower middle income setting, the PTSD prevalence was found at 14%, and in Brazil, the PTSD prevalence was found at 15%. It was also higher than that of ambulance personnel in the Northern American and Western European countries, where the PTSD prevalences range from 11% to around 20%. So possible reasons for the higher prevalence found in the study could relate to the study population. It could relate to the context in which our EMS personnel are working. It could also relate to the methodology that has been employed in this study or previous studies as well. So what we picked up was that previous EMS studies within the province were undertaken before 2014, so before the escalation of the attacks and the traumatic incidents that we have reported on in the background. They used a different PTSD scoring tool, and they also had relatively smaller numbers in their study. Given the escalation in attacks on paramedics in 2014, so participants in the study may be at greater risk of PTSD since the increase in attacks. They may also be more likely to have concerns regarding PTSD, and they may also have felt a greater need to report their PTSD symptoms in comparison to the non-participants who were not included in or who did not participate in the study. Another interesting finding was that of the PTSD prevalence being very similar in the support services and the operational services. And the possible reasons here was that those who were those who were operational staff who may have been diagnosed with PTSD could have been relocated or accommodated as operational as support staff. So removing one from the field to work in the call center, for example. And of course, it may also be possible that there might be a lack of skills in call center and support staff for support staff in handling secondary trauma that's associated with the taking in of calls, and of course working with telephonically with families and patients in distress may itself be an independent predictor of PTSD, and this was also found. This was also found in other studies as well. Other studies have found that though call center agents, though they may not be on the ground and experiencing the traumatic instance related to picking up a patient or dealing with a patient, are also, as I've said, dealing with the distress of the calls, the shift work, the impact of shift work, and other the lack of control as well with regards to the number of cases that are coming in, or the workload, have been shown to predispose those in the call centers to PTSD as well. So very similar to those on the ground. So with regards to some of the mental health problems that we picked up on, so having a pre-existing mental health condition may predispose to developing PTSD. And of course, this is more so in the presence of ongoing chronic and acute stress that has been associated with first responder work. Participants who reported having a mental health condition were more likely to have PTSD, and were more likely to report emotional problems in the past 4 weeks, withdrawal limitations. And of course, participants with PTSD were also more likely to report being on treatment for a medical condition. This was interesting, and it was a phenomenon that was also observed in Brazilian paramedics, as they also were shown to have more medical visits and hospital admissions in the last 12 months in comparison to those who did not have PTSD. With regards to exposure to critical incident stress and work-related stress, the interesting in our study was that the mean critical incident score, so 27.7%, was found to be higher than that of ambulance. Was found to be higher than that of in ambulance personnel. So in previous studies. And in previous studies using a very similar tool to the one we used, found a mean critical incident score of 21%, of 21, and this might be indicative of not only high exposure, but perhaps an increase in critical stress over time. So from the time the previous study was done. In terms of chronic organizational and operational stress, what we found was that the mean operational stress score that we found was 34, and it was comparable to that found by Donnelly in Canada. So they found a mean critical score of 32, and we used the same tool. But what was interesting was that the mean organizational score in our setting was 42 or 43, while they found a mean organizational stress score of 35. What does the impact of working in an urban area or in the metro mean? So in this study, we found individuals who worked in a rural area were less likely to develop PTSD. And this may be a reflection of perhaps the workload, with less exposure to chronic stress or less critical incident events compared to those working in urban areas. And it is of note, it was noted that urbanization in Ethiopia had led to emergency workers responding to more fire, road, and construction accidents. With regards to substance use, participants displayed quite high rates of problem drinking and the use of prescription drugs such as anxiolytics and antidepressants by 17% of the participants was interesting. So while it's not clear whether the substance use is because of PTSD or whether the substance use was already there, so even before people had PTSD, it does place them at risk of dual psychiatric diagnosis, so substance use disorder and PTSD, and it is more difficult to manage this in the workplace and has greater morbidity associated with it. So something that we definitely must have a look at. With regards to support, the study does highlight the important role that family and friends play when formulating interventions of reducing work-related stress. So there is a need to address, of course, the barriers of accessing support, including the fear that the services are not confidential or that the participant's career will be negatively impacted. In terms of training, it was clear that participants identified the need for training. The majority said that they didn't receive any specific training on how to manage stress or how to access the services. And this was very similar to a study that was done by Mini in ambulance personnel, where they also found within our Western Cape context that 72% of the ambulance personnel noted having received little or no training in managing the emotional effects of exposure to traumatic events. The role of resilience. So we did see a negative correlation between PTSD and resilience scores. So perhaps promoting resilience in ambulance personnel could be helpful in mitigating the challenges associated with ambulance work. But of course, and other studies have also found a similar thing, that lower resilience significantly predicted PTSD status. Of course, just a word of caution that while resilience training is an option, other interventions such as access to psychiatric screening by trained medical health professionals for earlier detection of PTSD symptoms should be considered while we address both the broader organizational and operational concerns that have been raised and that we know are prevalent in the service. The limitations of the study. Of course, there was a low sample size, which is a reflection of selection bias. The reasons for lack of participation could have been possible stigma associated with this mental health topic, responder fatigue. So there were other ongoing surveys at the time. Mistrust, perhaps, that the questionnaire would not be confidential, the fear that participating in the study might negatively affect one's work. And we tried to mitigate this by having extensive consultations with the staff, with labor unions and so forth before and during the study period. Of course, not all possible predictors of PTSD were included in the study, and they had to be limited due to the length of the questionnaire. Questions around childhood trauma and its impact. Other mental health screening tools could have been used for, measuring depression, anxiety, and so forth. General psychopathology. The gold standard, the gold standard was not used, so the gold standard test would have been using clinician-based diagnostic interviews. However, we did use validated tools that have been used globally, and though they have not been used very rigorously within the lower middle income setting, they have been used in quite widely in other settings. Social desirability bias might have creeped in, so participants may have responded in a socially acceptable manner. They might have been underreporting of mental health symptoms, they might have been underreporting of the substance use, for example, illicit drug use and so forth, and which may have reduced the study estimates that we are reporting. And of course, due to the nature of cross-sectional studies, no causal inference can be done, because exposure data and outcome data was collected simultaneously. However, concordance with the findings of other studies around the world and the biological plausibility do indicate that the significant associations that we found may reflect potential risk factors or correlates implicated in the development of PTSD in this population. Issues around recall bias must be considered because we did ask the participants to recall an incident that they experienced 6 months earlier. There was no control group in the general population. However, we did use the data that is already there from the MRC and others on PTSD in the general population. And we mustn't also forget the healthy worker effect, that the studies of occupational groups are vulnerable to the healthy worker effect. So this may have led to an underestimate of PTSD, as those who may have been severely impaired by PTSD, for example, at home or admitted, may have left the work service or their employer, leaving a relatively healthier population behind, which then participated in the study. Okay, so in conclusion, so PTSD prevalence was high in the ambulance personnel and markedly higher than the general population and in other previous studies, reflecting an increased risk in this occupational groupings. Those with a mental health condition, those receiving treatment for a medical condition, self-reported substance use, working in an urban area, exposure to high chronic and critical incidents are at increased risk. Support from family and friends, including co-workers, could form an integral part of interventions aimed or designed to support ambulance personnel. Greater attention needs to be focused on the barriers that have been identified as limiting access to available support for work-related stress. The efforts should be aimed at ensuring access to confidential, acceptable, and affordable mental health services, and this should be provided in a non-punitive manner, where individuals know that their career prospects will not be hampered by seeking help. And then possible interventions to reduce burden and the impact of PTSD. We need to address the high rates of organizational and work-related stress that are experienced. We need to also look at the various, deeper into these strong associations between PTSD and substance use that the study has shown. Further studies are, of course, needed that would involve clinician-based diagnostic interviews by psychiatrists and other mental health professionals, research into evidence-based methods of screening and managing ambulance personnel, development of appropriate interventions and protocols which are appropriate for our lower middle income setting, and research into the role of social support in managing work-related stress in ambulance personnel. And thank you much more to my supervisor, Professor Adams, Prof. Chibai, the head of department, and all the colleagues in our department, the HIA, and of course, the EMS colleagues who worked with us from the time the study started to now, and I see some of them are here. Thank you.
Thank you, Itumeleng, for the presentation. Before we go to questions, I see Dr. De Vries is here. And I was wondering if you would like to comment. Dr. De Vries is the head of the EMS services in the Western Cape. Shaim?
Hi, thanks, Shaida, and thanks Itumeleng for the great presentation. Really appreciate it. It's nice to have something with a number attached to it. Yeah, I mean, I guess intuitively we felt that was higher, that it was going to be higher than the 15% or the 6% reported previously. But I would be lying if I was hoping for a number as high as 30. But thanks for that. I think it certainly sheds a lot of light on something that has occupied far more of our time than we would have liked, and now we understand why. So yeah, I mean, I guess I just want to reflect on some of the findings. I guess the question it begs is what do you do with this? You know, so what are the implications for us as a service and as a department? I imagine it's probably higher than 30% considering what we've just been through in terms of post-COVID peak, where we saw a different kind of PTSD at that time. So yeah, so just thanks very much, Itumeleng, for pushing this. Really important work that needed to be done. Thanks, Shaida.
Thanks, Shaim. And thank you for facilitating the study, you and your staff, particularly the Occupational Health and Safety and Wellness staff who greatly assisted Itumeleng. I just want to ask everybody to mute their mics, and then the floor is now open for questions. So please put up your hand so I can see that your hand is up, and then, yeah, then you can pose your question to Itumeleng.
Shahida, Leslie's hand is up.
Okay, Leslie, sorry, I didn't see that. Leslie, go ahead.
So really great presentation, thanks you too. What I wanted to ask is, do you think there's also a high risk in other health workers? Because one of the registrars at WITS actually did a study amongst primary care providers at Joburg in Gauteng and found quite high rates as well. So how unusual is it? I mean, I don't want to be heretical about this, but you want to comment on that?
Thanks, Prof. So it has been shown to be high in other health workers as well, but particularly health workers who would be in the emergency setting, the health workers who would be in the psychiatric setting as well, particularly the acute services, the acute psychiatric services. So many of the other studies have been done to assess for PTSD in those populations as well. And Shaim also touched on it. We are also seeing that there has been studies that have been done in health workers, so general health workers who were involved in COVID care as well, and issues there relating to the anxiety around treating patients, one, but also the the impact of losing patients in the in the wards, losing patients in ICU in large numbers as well. The impact that may have had on the health professionals. So certainly there have been others. It is high PTSD or evidence of PTSD has been reported in other health workers as well.
Thank you, Itumeleng. Anybody, any other questions?
Shahida, Heather has a hand up.
How come I'm not seeing the hands? Go ahead, Heather.
Hi, can you hear me?
Yes, I can.
Yes, we can. Yes, go ahead.
Awesome. I've got a phone on one ear and the computer with the microphone, so it's a bit strange. I was wondering about the terminology of post-traumatic stress disorder, because it kind of assumes that there's an acute episode and now we're in a safe space to kind of process it. And looking at the critical incident definitions and stuff, I think that our staff, not only in work, but also in their normal sort of community lives, are actually exposed to this kind of thing on an ongoing basis. And I wondered if the tool encompasses that sort of continuous trauma type behaviors, or if it's specifically looking at more of that sort of like one acute incident and now we're struggling to process that. I don't know if that's a clear enough question.
So the impact of event scale, so that which measures the PTSD, so that it lists a number of 22 questions that are derived from the DSM-4 criteria of PTSD, and one would then have to score as to whether or not they have been experiencing any of those symptoms in relation to one incident. So one incident that the participant identifies as the most, being the most traumatic while in the line of duty. So we try to delineate it there. However, the tool that lists the number of critical incidents, I think there's 37 of those. We used a tool that was developed both locally by psychologists and compared it with that which also specific for EMS personnel in the Canadian setting, and the incidents there that are linked are those incidents that are related to both acute events, but also other more chronic events such as the media and how the perception the perceptions relating to how the community sees you and so forth. So it tried to give a much broader sense of the various situations, if I could use the word. Yeah.
So I'd also like to comment, Heather. I think it's a great question. And I'm not sure whether DSM-5 has incorporated into the sort of diagnostic criteria the issue of cumulative trauma over time and how that would increase risk for PTSD or be factored into the diagnosis. But certainly in sort of my clinical experience, I have seen that. I have seen sort of seasoned policemen, in fact, a policewoman, and there's still an event that seems to tip them into, where they now need to seek care. But it is usually sort of almost a repetitive, cumulative type of trauma over many years. And you see it in experienced people who often will sort of almost ignore it because it's like part of the job. But then eventually there's something that just, I think, overwhelms the coping mechanisms, or they reach a point where coping mechanisms are overwhelmed. Yeah, so just a comment from my side. Any other questions?
Thank you. So I'll just, if I can just add, because I think it comes into how we then respond to it. An ongoing competency within the organization, as opposed to like find the person who's just been exposed once to this thing and do an acute intervention.
I agree. Yes, it does call for more sustained interventions. Itumeleng, did you want to say something?
No, I was agreeing with what Heather is saying, that it does point to the need not only to focus on just that critical incident, but we've also seen that the call from the participants is that there must be much more better training, much more engagement, and what we are seeing, particularly with what we're picking up with the role of substance use, is, these are elements that would need to be looked into on a much more ongoing basis than just focusing on one critical event, one incident. Yeah. Especially in a context where within EMS, within a day you might be experiencing many or multiple very traumatic incidents in one session, and then repeated 2-3 days later, and so forth.
Yeah.
Are there any other questions? I just want to maybe then draw your attention to a comment that came from Siki, and she says that the differences between urban and rural may be attributable to issues of access, fewer EMS personnel, fewer ambulances, geographical distance, that often community members take it upon themselves to assume the role of first responders. It is possible that there may be a high incidence rate of PTSD amongst general members of the community, especially those who own cars, as they often have to step in and close the gap. So that's just a comment. Itumeleng, do you want to maybe respond to the comment, or?
No, thank you, Ziki. And what the studies have been, there's been both sides. So the one in some settings, some studies have found that those who are in a much more rural setting, particularly where there is lack of staff, lack of support, and so forth, might have been at greater risk. But it seems most studies are leaning towards the higher PTSD prevalence in the more urban setting, where there's much more there's much more frequent exposures to traumatic events and so forth. But I think it's a point well taken that perhaps in our setting, where working in a rural area might look protective, could be perhaps because there's a reduced frequency of calls and so forth, simply because people within the community are actually taking it upon themselves to respond. Yeah.
Thanks, Itumeleng. Any other questions?
Can I ask a question, Itumeleng? Thank you for that one. So I wanted to know whether differences between personnel who are based in urban underserved communities compared to the ones who are in your suburbia. So I mean, so for instance, if you're looking at Cape Town, people who work in Khayelitsha and Mitchells Plain, did they report higher incidence of PTSD and related moderators compared to somebody who is based, in your more affluent suburbs?
Yeah, we haven't. That's something that we can look at the next phase. We didn't disaggregate the PTSD, up to that granular level, but it is something that we can certainly look at, comparing the areas. But we can even use areas that are defined as red zones, for example, by EMS, and compare them to areas which are not red zones. And the red zones are those areas where there would be a need for police escort, and there's been traditionally much more increased adverse events or adverse incidents. But at this point in time, we hadn't done that disaggregation.
Thank you.
We'll take one more question from Shaheem. Wants to say something? Go ahead, Shaheem.
Thanks, Shaida. Not so much a question, but add on what Nsiki has raised. So, I mean, I guess we're pretty crappy at servicing all the communities, so there's not really underserviced in the city. But having said that, if we look at the communities themselves and the different socioeconomic issues they deal with, I think the question that we could ask is whether or not the residence of the practitioner, in other words, do they stay in these red zones, made a difference to either their exposure to PTSD or their prevalence of PTSD. I think that is certainly something that deserves exploring. I think we are a traumatized society, and it is conceivable that as much trauma occurs in some of our non-work related lives, depending on where we live. So I think that certainly is a question worth asking. Thanks.
Itumeleng, did you collect data? You collected data on where they live, hey?
Yes, we did.
So we could certainly look at that, I think.
So yeah, I think we can look into that as well. I'm just very quickly trying to look at our broader results, but I can't really pick it up right now. But we did look into that. Yeah.
Okay, and then Samir had a question. We're going to finish up now. I'll answer Gavin's quickly. Gavin asked, wondering if this high prevalence of PTSD is also present in our hospital emergency unit staff, and the previous work done by Registrar at Wits that Leslie London referred to, I think, looked at PTSD in emergency staff. So doctors, I'm not sure whether it included nurses. So there has been work done. I think it's pretty high, if I remember. I don't remember all the details of it. It was about a year or two back. And then Samir Charlie wants to know what the level of absenteeism is that is related to PTSD. Did we measure that, Itumeleng? I think we did. Lost work days? No?
No, we didn't.
Oh, we didn't.
We didn't.
Yeah, because so this was a screening tool to look at PTSD risk, and based on the screening tool, if you scored over a certain percentage, then clearly you are at sort of very high risk for PTSD, or it's suggestive that you actually might have PTSD. It would still require the sort of gold standard of a clinical interview by a mental health professional to establish PTSD. If one wants to know about absenteeism related to PTSD, the other way to go about is to look at sort of actual sickness absence data, and that is there. We did initially think of doing that. But, it would have given us a more limited sort of view because we would have relied on the PTSD that gets reported. And our suspicion is that a lot doesn't get reported because of access to mental health care and things like stigma and all of that. And so we decided to rather go sort of broadly and give everyone a chance to participate. Do you want to say anything else, Itumeleng, before we close off?
Just adding to that we also shied away from that because it would have needed us to link the PERSAL or the individuals and their sickness absence data with their PTSD score, and so just to avoid that and to ensure that it was anonymous, we then decided against linking the absence data with the PTSD score that would eventually be found. But I was just highlighted there is I didn't present these, but we did look at the impact of your living location, and it appeared initially that living in a rural area was protective against PTSD. However, that was not statistically significant. So that was just at the level that we left it at, just to answer Shaheen. Thanks.
Okay, so thank you very much. I can see Itumeleng is a popular man. The noon meeting is very well attended, or maybe it's a topic, but you know where to find him. So I'm sure he'd be happy to field any sort of further questions or, any further issues that you might want to discuss or take up with him, particularly those involved in EMS. We do plan to do a sort of more structured and formal feedback to the EMS department and the workers there. And I think he also plans to refer those that potentially could be at risk, to inform them of their score and inform them that they could be potentially at risk, and that should these symptoms persist, they should probably seek care. So that is sort of to close the loop on the research and to feedback to the participants. Thank you very much to everyone, and thanks to Itu for a great presentation. Well done. Thank you.
Thank you, everyone. Bye.
Thanks, Shaida. Thanks, Itumeleng. We appreciate it.
Bye.
Thank you so much.